Okay. So memorizing is not the issue. If you memorize the content, it's a lot. The books are big. NCLEX has so many information for you to learn. It's just like you have been in school for 3 years. You have been in college for 3, 4 years. And these are all the materials you've been learning. They expect you to know them. They expect you to be able to use them on the exam. So memorizing is really not going to be a helpful option, but try to understand the content part of it. When it comes to figures, lab values, and all those numbers, you can memorize them. I'm not saying memorizing is bad. It's not bad. But just to let you know, it's not the best option if you just want to understand the material, because it's not straightforward content you are answering. They're not giving you a comprehension questions to go and write, give us the anatomy of the liver and you start drawing and explaining it. No, that's not what it's going to be. It's going to be in the analysis and applications. So when you study, understand about the liver, understand about the topic, and then you try to test yourself with questions that analyze your application and your analysis ability for those topics. So today we are going to move to our renal system medication. So I had given you an image of the renal system. We have gone through the renal system as well. We have explained the various tests or diagnostic tests that will be done if a patient has a renal system disorder. And I had told you last week about the inflammatory processes, and I told you about increasing fluid volume when a patient has an inflammatory process going on. So let's talk about the renal system medications today. So I spoke about urinary tract infections, and these are medications for the urinary tract infection. So if a patient has UTI, urinary tract infection, cystitis, that was the topic for last week. So cystitis, if a patient has inflammation of the urethra, cystitis. So these are the medications that they will give to the patients. I'm just going to check and see if I sent you all that right now, because I know I did send you. Yeah, I sent it. Urinary system, renal system review, and renal system medication. Please find attached are the study materials for this week. I did send you that, but let me see, maybe I made a mistake. Okay, so I did send a message, but I think I did not attach the medication part of it. Okay, so let's talk about it. I will send it after the class. Urinary antiseptics. So these medications are urinary antiseptic medications. When we hear antiseptic, remember they were talking about mostly a bacteria involved, E. coli. So we have amoxicillin, cefixime, fosfomycin, metanamine, nitrofurantoin. These are antiseptics. So the urinary tract antiseptic, they inhibit growth of bacteria. They stop the growth of bacteria in the urinary tract, and they act as disinfectant within the urinary tract. And these are used to treat acute cystitis or UTI. I told you UTI is the same as cystitis. So urinary tract antiseptics do not achieve effective antibacterial concentration in the blood tissue, and therefore they cannot be used for infections outside the UTI. So if it's an infection that is not within the urinary tract, you cannot use them. So let's say you are having you're having shortness of breath and you go and take fosfomycin. They are not to be used outside of a UTI problem. So you would definitely be trying to tackle your kidneys or your urinary system when you're taking this particular medication for other things. Antibiotic can be used for other things. So when you look at these antiseptics, you might say this one looks like it's an antibiotic. Yes, it is. It can be used for other things based on its component in it. You have some of them that you cannot use. You cannot use nitrofurantoin when a patient does not have any urinary problem. So you cannot use that. So antiseptics they are meant to achieve effective antibacterial concentration in the blood tissues. So because of that, you cannot use them for infections that are outside UTI. So what are the side effects and the nursing considerations? So the medication, oh, I think, did I put that? Okay, so I have them divided under each of the medications. So phosphomycin, what is it? So these are the side effects and the nursing considerations you look when you are caring for a patient who is taking that medication. So the medication is available as granules and it must be dissolved. So you want to instruct the patient to mix the content of a packet in about half a cup or 120 cc of cold water. You tell them to stir it and then they drink it. So you mix it in a cold water, tell them to stir it and they drink it. It's like granules. You pour it and then you stir it and it mixes up. So this is your nursing knowledge, nursing instructions, nursing considerations. So this is what application level questions we want to see if you know. So they want the client has an order for phosphomycin. The nurse walked into the room and you're about to administer the medication. The patient asks you, how do I take this medication? Since there are a little granules inside the capsule, how do I take it? So application level, you should be able to tell the patient, the medication has its granules. So I have to pour it in a half, at least the water should be about half a cup, which is 120 cc, and then I will stir it mix and you drink it as a liquid. So this is application. You are applying your knowledge of what phosphomycin is because it has to be dissolved. So the patient tells you, oh, I am home, I have this order in the house, but I always swallow the capsule like that. And I think I like it better because when I swallow the capsule like that, I don't get to feel the taste. That's a wrong statement. You have to educate the patient. So this is where your nursing interventions come in, or nursing consideration. As a nurse, you have to come back. Oh, if you keep swallowing it as a full whole pill, that's not how it should be swallowed. So you have to educate the patient. This is how NCLEX twists your knowledge with the content and they ask you questions. So metanamide, it is used to treat chronic UTIs. So we have patients that have recurrent infections that keep going and coming, and it is not recommended for acute infection. So if I never had UTI and today I just present with UTI, that would not be the first medication you give me because this is for chronic UTIs. Chronic UTI. So you administer after meals and bedtime to minimize gastric distress. So that means that medication has an effect on the abdominal system or on the GI, because remember it's a pill you have to swallow. So you have to give it at bedtime to minimize gastric irritation. Chronic high doses therapy can cause bladder irritation. So chronic high doses. So when you keep loading the patient, it can cause bladder irritation. And it can cause crystalluria and should not be used in clients with renal impairment. So the patient will be peeing and it make the urine, like it kind of form crystals in the urine that can also lead to renal calculi, kidney stones. So for patients who take that one, you want to also take notice of that. It should not be used with patients with renal impairment. So if the patient has a history of kidney stones, kidney stones, you want to minimize their use of this medication, or you don't want them to use it. So the composition of the medication generates an ammonia. Therefore, it should not be used for clients with liver dysfunction. Now we know that the byproduct of the liver is ammonia, if I remember well from my GI system. So anything that has to do with ammonia, we want to link it to the liver. So because the medication has a decomposition effect on the liver, you don't want to give it with patients who have problems with the liver. So methanamine also require acidic urine with a pH of 5.5 or lower. This is when you do the urine dipstick, when you run the urine for urine analysis, you see the urine pH on it. So if the patient urine is not acidic, you don't give it. So the patient's urine, if it's acidic of 5.5 or lower than 5.5, you can give it. So the urine, we know the normal pH, it should be at least above 7, 7.2, 7.35. So if the pH is that low, that's acidic. If it's too high, that's basic. So, and if it's low, you can give it. But if it's not low pH in the urine analysis that you will do, you don't give the medication. Now, clients taking this medication should avoid alkalining agents that include over-the-counter antacids containing sodium bicarb or sodium bicarbonate. So that means this medication has an effect on that. That's just opposite of what they said about the pH. It has to be acidic. The patient's urine has to be acidic for the patient to get it. So if the patient's urine is more of alkaline, that is above 7.45, the patient's urine is high. If the patient pH is higher, you don't give it. That's just the opposite of this. So it's more of an alkaline. If the urine reads more of an alkaline, you don't give alkaline content to this patient who is getting this medication. So if the pH is not low, you don't give it. That means it has effect with alkalining agents, and antacid is one of them. Sodium bicarb is one of them. So it will not work in that patient. Now let's look at nitrofurantoin. What is it? This one is gastrointestinal effects include nausea, vomiting, diarrhea. Administration with milk or meals will minimize GI distress. So for most medications that has direct effect on the GI system, that can cause nausea, vomiting, and all those things, you always want to administer it with milk or with food. Milk will minimize the effect of GI irritation. So take note. So nitrofurantoin is a urine antiseptic. It's not a cardiovascular medication. It is given with GI irritation. We have pulmonary reaction. So if a patient is taking that one, pulmonary reaction will include chest pain. Patient can complain of chest pain, chills, fever, cough, alveoli infiltrate. This resolve in 2 to 4 days following cessation of treatment. So if the patient has that complaint, then the patient will have to stop taking the medication. So you advise the patient call you on the phone and is explaining, I was recently there yesterday, I got treated for UTI. They gave me 1 capsule and I started taking the capsule. I don't know the name of the medication or I cannot mention it, but I realized that when I took the medication today, I wake up, I feel I have chills and I'm coughing and also feel a little bit chest discomfort. So you will have to advise the client to stop taking the medication and seek medical attention right away. So that's where they will now follow up to advise the patient to stop taking it for 2 to 4 days and the symptoms will relieve. Now we have peripheral. That one I just said is an NCLEX style question. So take notice of things like that I say. So we have pulmonary, I said that hematological effects will include granulocytosis, leukopenia, thrombocytopenia, and megablastic anemia. So these are the effect it will have on the hematological system. So that means this medication will affect GI system, it will affect pulmonary system, it will affect the hematological system. Now let's look at peripheral system. The peripheral, it has effect of peripheral neuropathy effects, and this one will include muscle weakness, tingling sensation, and numbness. Neurologic effects will include headache, vertigo, drowsiness, and nystagmus. Allergic reaction will include anaphylaxis, hives, rash, and tingling sensation around the mouth. So this is the allergic reaction. So if you're allergic to this medication, these are what you will get. So these are not good signs you want. You have the expected signs and those that you don't want them. Nitrofurantoin may impact a harmless brown color to the urine. Remember when they start asking of urine colors and all those things, NCLEX like to tamper with people about that. They want to know what urine color will this medication cause. Those TB medications, they'll ask you that. They like that question so much if you never remember. They like to ask what color. So the patient tells you my urine is bloody. I started taking medication for my tuberculosis yesterday. My urine is bloody today. What medication would the nurse suspect that the patient is taking it? Rifampicin. So take notice, those are the things. So nitrofurantoin can also change your urine color to harmless brown color. So it will look brown, you might think it's blood, but when you are taking nitrofurantoin, you have to understand that it's not blood, it's the medication side effect. This brings me to a memory of, what's the name? One GI medication that I took last year. I never read the side effects of the medication. So, what medication is that? One of those drinking one. It's in my kitchen, I forgot the name. So I took the medication and then 2 days later, I realized that my stool looked black, very black like charcoal. Very, very black. And I know that black tarry stool is a sign of GI bleed. So I had only abdominal discomfort that I took that medication and I know it's worked. Is it Mega Seed? I forgot the name of that medication. It's in my drawer right now. So I got nervous. So I'm like, what could cause this? Even when I took it, I don't have the pain no more, but why should my stool be that black? So I was like, I need to go and see a doctor. But something told me, can you go and read the medication? Because that's the only medication you took. So I went to take the medication paper and I read it. Then I realized that if you start taking that medication, your stool can be black. It's not, it doesn't necessarily mean you are bleeding in the stomach, but it's the medication. So I was nervous because I didn't read the side effect before I took that medication. It's a common medication people take. So I was so used to it. But let's look at this. Nitrofurantoin is contraindicated with clients with renal impairment. So most of the medications you want to give that is antiseptic, and they are strong ones, they are contraindicated with renal impairment. So this is the second medication that is contraindicated with patients who have renal impairment, kidney stones, kidney failure. They are contraindicated. You don't give them because they'll further cause more harm to the renal tubules, or they'll cause crystallization. Now, instruct the client in expected side effect, signs and symptoms that warrant notification of the primary healthcare provider, and not to take nitrofurantoin with antacids. So take notice of that statement. You instruct the client not to take nitrofurantoin with antacids. This can be a potential question. So the patient taking nitrofurantoin tells you, oh, my stomach was heavy yesterday and I think it was good. I started taking antacids. That's a big no. So you have to tell them not to take it together. As I have explained the pH levels above. So the urine pH should be lower. It shouldn't be higher. It should be more acidic. It shouldn't be more basic. So let's look at fluoroquinolones. This is another group of medication. We just finished urinary antiseptic medications that are given for UTIs. Now let's look at fluoroquinolones. I didn't talk about These two, they are antibiotics. I will get to them later, but just to let you know, they can be used as urinary tract antiseptics. But these are the only three that are more concerned of a kidney issue. Fluocinolones. Then we have these ones, we have Cipro, Delafloxacin. So fluocinolones, take them as a fluoxacin. Okay? Let's take them as medications that has to do with the fluoxacin. When you see the FLOXACIN, they are under fluocinolones, and they are under UTI treatment. Okay? So this one suppress bacterial growth by inhibiting enzymes that are necessary for DNA synthesis. Active agents against a broad spectrum of microbes. Side effects and adverse effects and nursing considerations. So they can cause dizziness. So when you start taking Cipro, Levaquin, remember this one is special, right? Levaquin. So all those fluocinolones, they have other names, but remember the fluoxacin will take you to fluocinolones, and they suppress bacterial growth by inhibiting the enzyme that is necessary to synthesize DNA. So they are broad spectrum of microbes. They work against broad spectrum of microbes. It's not one microbacteria. They work against broad spectrum of microbacteria. So they have drowsiness, dizziness, gastric distress, diarrhea, vaginitis. So the patient start telling you, my vagina itches, and they say they keep scratching, vomiting. Now the adverse effect will include psychosis, hallucination, tremors, hypersensitivity, and interstitial nephritis. So these are not the expected side effects of the medication. So these are not the expected action of the medication. You don't want these ones. So these are adverse effects. It affects the patient negatively. So if a patient is taking Cipro, and today the patient come in and is confused and hallucination, what do you think is going on? That means the patient is having an adverse reaction to the medication. Or they tell you the patient came in, was treated with UTI, went home on prescription. The patient came back today, and the patient started hallucinating. The patient has tremors and confusion. Which of the following medication will the nurse suspect as the cause, or will the nurse first ask the question, the patient, if the patient take that medication? It should be one of the fluocinolones. If they mention any of this in the answers, you pick one of them. So with fluocinolones, there is an increased risk for tendonitis and tendon rupture. The Achilles tendon, I'm not going to go into that one. Let's leave that one aside. We are not worried about that. Let's take notice of the adverse effect here. So clients at risk are those over the age of 60 years, those taking corticosteroid, and clients who have undergone organ transplants. So clients who are at risk for this medication, or who are at risk for taking this medication, are those who have undergone organ transplants and those taking steroid. So fluocinolone should be used with caution in these patients. So patients who have hepatic and renal problems, central nervous system disorder. Remember the patient, it has psychosis, hallucinations, confusion, and all those things. So central nervous system disorders. Then you want to monitor the client for the side effects. Cipro and oxaflozacin may be taken with or without food. So it is fine to take these medications either with food or without food. IV administration of Cipro and oxaflozacin are infused slowly over 60 minutes to minimize discomfort and vein irritation. You advise the client to report dizziness, lightheadedness, disturbances, visual disturbances, increased light sensitivity, and feeling of depression, because the signs could indicate central nervous system toxicity. So if I am you and I'm studying for this exam, I will go over this symptoms presented again. They are giving you symptoms of central nervous system toxicity, and the symptoms that you advise the patient about if the patient is taking a fluocinolone. So the signs are dizziness. The patient that presents to you with dizziness, lightheadedness, I have visual system disturbances, I'm sensitive to light, depression, I feel depressed, and the patient is taking fluocinolones, Cipro. You want to think the patient has central nervous system depression. So that's an advice. You, the nurse, will educate the patient on that medication. But you need to understand that when the patient report those symptoms, it's a central nervous system involvement. Then we have administer fluocinolones with a full glass of water and ensure that the client maintains a urine output of 1,200 to 15 cc daily to minimize the development of crystalluria. Remember, I already told you about the urine crystal formation. So crystal formation. So you want to encourage the patient to take more water, more fluid. Now let's talk about sulfonamide. They suppress bacterial growth by inhibiting the synthesis of acid, folic acid, active against a broad spectrum microbes used primarily to treat UTIs or acute UTIs. Remember the first medication we talked about, you are not supposed to give this with acute UTI, mostly in chronic UTIs. So we are still looking at medications that are given with bacterial infections and urinary tract systems. Now we are talking about sulfonamide. So sulfonamide, we have the sulfadiazine, sulfasalazine, sulfacetamide, and trimethophan, that's sulfatomazole. Yeah? Sulfamethoxazole. Pardon me, okay? I'm not used to these names. I just know them. So try to know them. The side effect for this medication, so these are sulfonamide. So when you see the zine, the sulfazine, sulfur something zine, and you see the sulfamethoxazole. So take the name sulfur in the beginning. Take the name sulfamethoxazole or sulfur something in the beginning for sulfonamides. It goes in order. So they have their side effects and what you, the nurse, will be concerned about. So the nursing considerations are what you, the nurse, will be concerned about and what you probably instruct the patient to do. So you'll be concerned about hypersensitivity, which will be rash, fever, photosynthesis, Stevens-Johnson syndrome, the most severe hypertensive response. It will produce symptoms that will include widespread lesions of skin mucous membranes, fever, malaise, and toxemia. So Stevens-Johnson syndrome, the patient will produce with severe high blood pressure. The patient will have lesions on the skin and the mucosa membrane, and then there'll be fever, malaise, and then toxemia. So sulfonamide can cause hemolytic anemia as well, agranulocytosis, leukopenia, that's elevated white blood cell or in the blood. Then we have thrombocytopenia. Instruct the client to tell their doctor if they have a fever or a sore throat. You want to give sulfonamide with caution in clients who have renal impairment. So take this one for a notice that patients that take UTI medications, urinary tract infection medications, we have the sulfonamide, we have the fluocinolones, and we have nitrofurantoin, methanamine, fosfomycin. These medications, you want to educate the patient not to take them when the patient has renal system impairment. If the patient has renal system impairment, they don't take it. They are used to treat urinary tract infections. But if the patient has an underlying, the patient has chronic kidney disease, they try to avoid that as much as possible. Please, if you have ever seen somebody do it, if you have ever been administered with any of these medications and you have a history of chronic kidney disease, please don't answer that as a correct answer in the envelope. Sometimes the doctors will override stuff and because they think of the way the advantages and the disadvantages. So that's clinical. And I have always made you guys know that whatever you see on the clinical level, don't apply it to NCLEX, because clinical level, we have facility procedures that take effect as well. But you, the nurse, you are a general nurse. You haven't gotten to that level yet. So when you see these things keep happening, don't put it as part of your business to be using things to answer questions for NCLEX. You can be asking questions about signs and symptoms patients present and they get diagnosed with certain conditions, but don't use what you see being done at a clinical level, especially if you happen to work in a facility. So sulfonamide should be withheld if a rash is notified. You want to hold that medication, then you inform the primary care provider if a rash appears. So the moment a patient has a rash and is taking sulfonamide, that's an adverse effect. You don't want that. I do have a bunch of the instructions here, but one here is to give the patient full glass of water. Sulfonamide can potentiate the effect of warfarin, phenytoin, and orally administered hypoglycemia. It can potentiate the effect of it. It can kind of, it requires, like, it can increase the effect. You know, when a patient is taking Coumadin, phenytoin, those medications, they monitor the levels. So when the patient starts taking sulfonamide, it can shoot up the levels higher. So you want to know, they have to take that in reduced doses just in case they need them. So sulfonamides are also contraindicated in infants that are younger than 2 months and in pregnant women or mothers who are breastfeeding. Mostly you want to take note, a lot of medications, especially antibiotics, they try to withhold them from pregnant and breastfeeding mothers. So take notice of that. It is also contraindicated if a person has existing sulfonamide or loop diuretic medication, if the patient has underlying side effects. So if you had reacted to a sulfonamide, silver sulfadizine years ago, then you are at risk for, you are contraindicated from taking that medication. So instruct the client to prolong exposure, to avoid prolonging exposure to sunlight, to wear a protective clothing, and then apply a sunscreen to exposed skin. Adults should maintain a daily urine output of 1,200 cc. So you see, so far, patients that are taking medications for their UTI, they encourage them to have a urine output of at least 1,200 to 1,500 ml. MLCC is the same thing, that's 1.5 liter. So they should have a urine output of 1.2 to 1.5 liters, and that will help. And they should consume 8 to 10 glasses of water because you want to flush it out. So people that have UTI in general, you want to encourage them to drink fluids. That will help clear out the bacteria from the urine, from the urinary tract. So let's look at urine analgesics. You know, we have like the analgesics for pain, right? So urinary system also has their own analgesics that you can use to treat pain. So urinary tract analgesics is administered with an antibiotic because the analgesics only treat pain, not the infection. So the analgesics are only there for pain. Just like we know we give patient analgesics for pain. So we have pentosane, polysulfate sodium, and phenazopyridine. I don't know how many of you have heard this particular medication, but they like to ask it. Phenazopyridine is for pain. Urinary tract or urinary system pain medication. So that's an analgesic for urinary system. So the side effect for that medication will be vertigo, headache, nausea. So the NCLEX will present to you like a patient was started on phenazopyridine 3 days ago. The patient presents to you, and then instead of mentioning vertigo, they start telling you dizziness. The patient have this, they give you the symptoms of vertigo. Patient presents to you with dizziness and feeling pain, having pain. and this and that. Light. You want to know that vertigo is a side effect of urinary system analgesics. That's what I'm just trying to carry out. Nursing consideration, you instruct the client that urine will turn red, orange. So if the patient is taking this one and come to you and says, my urine was red, my urine is this, and I'm concerned, you want to tell them it's unexpected, it's not a harmful one, and you strain and could stain their clothing. Tears and contact lenses will also become red of orange tinge urine. So you instruct the patient that their urine will turn red orange and it could stain their clothing. So you be careful, don't accidentally pee on yourself, or don't let that urine touch your clothing. Okay, then we have your tears, the tears and contact lenses. So the tears that the patient will have will also become red or orange tinge. So if tears are coming out of your eyes, you have to be careful it doesn't drop on your clothes, because your clothes are also going to turn red or orange tinge. It will stain. Now, urinary tract analgesics is contraindicated in clients with renal or hepatic diseases. Another contraindication, so patients that have renal problems, chronic kidney disease, they are contraindicated from taking renal analgesics. The medication interferes with accurate urine testing for glucose and ketones. So usually you check ketones for dehydration. So if the patient is taking that medication, you can get inaccurate urine testing. When you run the urinalysis, the glucose and the ketones might give you a false result. Now let's look at anticholinergic or antispasmodics. So this is how I treat this particular one here. So when I see the antispasmodics, something that inhibits spasms in the urinary system. So let's see, they use for overactive bladder. That's urge incontinence. When you feel like you have to pee, you have the urge, but that you still have continence, you're not able to release the urine. So anticholinergic, antispasmodic medications are these ones. So like I was telling you about the memory, when it comes to medications, memorize them in groups. So you know that when you start seeing phenazopyridine, or like pentosane, some of those are not in order. But when you look at the sulfonamide, they were all in order. So they all have the same beginning. Memorize them like that, so that those that are specifics with different names, then there are those you are worried to understand where they belong. But sometimes you just need to see it. And when you see it in the exam, your mind will tell you where this medication will belong to. And sometimes the description of the whole question process and what they want you to tackle will click your mind. If you have ever come across this medication when you are learning, it will click your mind that based on this question, this medication comes from that class. And then you pick up the right answer. So pharmacology is another thing to worry about, but you need to understand for most of them, they have classes. So you understand them by classes. So we just talked about anticholinergics, antispasmodics, and these are the medications that fall under these medications. I'm not going to go over them, but this is a common medication that they give, the oxybutynin. They give it so common. Diclomine, they give it very often. Let me see which one again. The Flavozet, they give that one too very often. I had given some medications from the TV. Did we receive it? I think Clementina got that. Anyway, now your group.
Which is the other one, patient?
Is there?
Which is the other medication you said? Yeah.
The other medication I said?
Yeah.
That's the Flavozet.
Okay.
Yeah, but I'm talking about medications. I had given some medications that are commonly used TB medications. We have some medications that the NCLEX got interested in because the public tend to patronize it, and it has not been grouped in the books yet. So those medications come on the television. You see them advertising it, diabetes medications, and they're telling you the side effects and all those things. I had given a list of a couple of them out. So try to also take notice of those television medications.
I didn't get the medication.
No, you didn't get it. It's not your group. Your group, I haven't given it to any of you, but I'll give it out one of the days, okay? I try to put them in order. I don't want to load you with materials that you cannot study. So I make sure you study and then you produce a feedback before I give you. Side effects and adverse effects of anticholinergics. Anorexia, nausea, anorexia, nausea, vomiting, and dry mouth, blurry vision, confusion in adults, constipation, decreased sweating. These are, just take this. It's a lot of them, side effects. So NCLEX will not ask you all of these side effects. They will just present to you with some of them. So just know that they are all side effects to expect with most of medications that you take. So I do understand that when it comes to some of this, it's not like a specific side effect to take notice for. Let's look at nursing considerations. This is where application comes from. This is where you'll be able to apply your nursing knowledge of what is going on with a patient taking anticholinergic, antispasmodics. So I have the nursing considerations. Extended release capsules should not be split, chewed, or crushed. I have said that before. This is not the first time. Extended release medications, you don't chew them, you don't crush them, you don't split them. So you walk into the patient's room, or the patient came back to the clinic and you are the nurse today. The patient says, oh, the doctor ordered, let me see which of the medication. The doctor ordered one medication, oxybutynin. I don't know the name, but I also see an extended release, or the patient will just mention the name of the medication to you and it's a capsule. Tell you, I don't know the name, is a capsule, and the patient show it to you and you see the name on the label. It tells you it's extended release capsule. Then the patient tells you, oh, I always chew this medication and I like the taste, I'm enjoying it. So it should not be any of that. You have to teach the patient to swallow it whole, as a whole medication. So that's a wrong statement. That means the patient didn't understand the instruction when they were discharged or when they were given that medication. You have to re-educate. That's application. So your knowledge about the fact that that medication should not be crushed, chewed, or splitted into two is what would drive you to apply that knowledge in educating the patient. That's where application and analysis come from. So you analyzing that this patient telling me this, that means the patient did not understand, but this is what it should be. So understand the application and analysis level when you are reading the content. We have tolterodine should be used cautiously in clients with narrow angle glaucoma. So if I am you, I will take notice at this point. I'm not sure how many of you are taking some little chichis from this, but it is always good to take little chichis when you are listening to somebody do a presentation to you, because most often that gives you a good memory. It helps you remember them. And I always tell you, you can repeat these videos at your own leisure time. Most often you don't have to go studying the whole material, but repeat the videos and listen to them as much as you can. They help. They help, actually. So you don't want to use this medication if a patient has narrow angle glaucoma. So it's contraindicated or is used cautiously. So before the patient uses it, they will have to weigh the advantages and the disadvantages, and the patient will have to be monitored. Do not administer oxybutynin to clients with known hypersensitivity, gastrointestinal, genitourinary obstruction, glaucoma. So listen, if I am you if I am all of you, now let's look at another medication. Do not administer propentalen to clients with narrow angle glaucoma again. GI distress. Let's look at the trend of all those things they are mentioning. Let's look at the trend. Glaucoma. Let's look at the trend. So you have 3 of those medications from the anticholinergic, antispasmodic class that they are telling you not to administer with a patient with glaucoma, narrow angle, patient who have GI, genitourinary problems, and patients who have glaucoma issues and narrow angle glaucoma. If I am you, you put all these things. Any medication that is antispasmodic, if I am able to identify it's antispasmodic, I know that medication should not be given with a patient who has glaucoma or patient who has GI problems. That's how I will group it. So you group it and then you are safe. So if you pick narrow angle glaucoma as a problem when a patient is taking oxybutynin, you are not wrong on the NCLEX. Instruct the client to avoid hazardous activities. Of course, any client that is taking it, you avoid hazardous activities. Nobody even wants to do hazardous activities in the first place because the medication has drowsiness and dizziness. So when we looked at the signs, we saw all these things. So other medications will also cause that. So those are things you always want to tell patients to avoid. Now you monitor the intake and output. That you always do, I keep saying it. And then provide gum or hard candy for dry mouth. So that is the medication, antispasmodics have effects of causing dry mouth. So you offer them candy, hard candy to suck to help them produce more saliva to keep their mouth wet. Then you want to monitor for signs of toxicity, central nervous system stimulation, vertigo, and all those things, such as hypertension, hypo, confusion, tachycardia, flushed or red face. These are signs of vertigo, hallucination, restlessness, and irritabilities as well. These are other signs that you want to tell the patient to be mindful of. Antispasmodic medications used to treat overactive bladder, urge incontinence should not be used by clients who are diagnosed with narrow angle glaucoma. So listen, I have mentioned that already. Narrow angle glaucoma, the medication will block the flow of intraocular and raise the intraocular pressure. This may cause permanent damage to the optic nerve. So antispasmodic and narrow and open angle or narrow angle glaucoma, I wouldn't even advise it. I wouldn't even pick an answer like that to favor antispasmodic. So if the patient is taking that, you know that they are contraindicated. That's the main thing you take from this if you didn't get anything. Then we have anticholinergics. Anticholinergics. Oh, is that a repetition? Yeah. This is repeated. Anticholinergics, antispasmodics. Yeah. Down here is repeated, so I'm just gonna jump that side. So okay, so I'm gonna jump this whole side. This is basically the same information. Let's look at medications for preventing organ rejection. Medications to prevent organ rejection. Can we take a 15-minute break and come back? I'm not hearing anybody respond.
Yes, good.
I'm not sure if we are on.
We are here. We are here.
Okay.
Let me see how far we have gone, but I want to finish this topic. Yes, we are almost there. I think so. Let me see. We don't have too much to do. Yeah. So
Garbage.
we are going to take a 15-minute break. When we come back,
we're looking for foil paper tray.
When we come back, we'll finish the topic. Is that okay?
Okay.
All right.
Okay.
So we are going now. We are going to come back at 45. 7:45, okay?
Okay.
All right. So I will see you later.
Okay.
But before we go, do we have a question? Does anybody have a question so far? I have talked about urinary system medications. It's not too much. Urinary system medications are not voluminous. They are not too much. You just need to understand the classes. The analgesics, you understand the antiseptics, you understand the, which one did we just, the anticholinergics, antispasmodics. So far, we just talked about 3 of them. And all of them are contraindicated in patients with renal problems. And you want to encourage fluid intake. And you know, anticholinergics, antispasmodics, they are contraindicated with patients who have a diagnosis of narrow or open angle glaucoma. So you want to take notice of that. So I will see you in 15 minutes, okay?
Thank you.
Okay. Thank you. All right, so we are continuing from organ rejection medications that help prevent organ rejection. I had mentioned to you when we spoke about kidney transplantation, the donors, it has to match, they have to screen the donors, and then they have to put the patients that get organ transplant or kidney transplant on medications for life. So these are the medications, they give it to you, and we have the hyperacute rejection, we have the acute, and we have the chronic acute rejection. So those 3 rejections, the hyperacute was the one that I said it happened within 48 hours after the kidney transplant, and the intervention is they take that kidney out right away. The acute one will start in months after you get it, and then they try to put you on immunosuppressive medications, immunosuppressants. They try to put you on those medications to help maintain the kidney, to help have it stay back, not to come out. And then the chronic one is one that will happen years after, and it just stays. So that they maintain you on the medication as well. So medications that help prevent kidney rejection will include immunosuppressants. Now listen, it's not only those who get the rejection that take the immunosuppressant. Whether you're getting a kidney rejection or not, when you have an organ transplant, they put you on immunosuppressant medication. They put you on medication for life. So they have medications, and those medications are very expensive. So we have immunosuppressant, steroid, cytotoxic medications, and antibodies. So some of the medications may be used in combination to produce different actions on the immune system. Combination therapy will also allow for the medication in lower doses. So if they are combining 2 of the immunosuppressants, they have to put them in lower doses. So if those 2 medications are both immunosuppressants, they will be low. If they are steroids, they'll put them in low doses. They can't give you higher doses of steroids at the same time. So if they're giving you 2 immunosuppressants, they are in low doses. So some medications may be used in combination. I just said that. Now let's look at medications for preventing organ rejection. These are the medications. They are not too much to learn or too much to understand, especially urinary system don't have too much of medications. You just need to understand that antiseptic, antispasmodic, anticholinergics, sulfonamide, which fall under UTI medications. And then you come to the rejection medications. So we have cyclosporin, Solimos, we have the tacrolimus. So remember, these names that I have, they are the brand names. NCLEX like to use brand names. So I try to go with the brand names, okay? But on the NCLEX, they like to use this one and then they put it in bracket, the generic name.
I'm not seeing anything.
Oh, you're not seeing?
I'm only seeing you.
I'm sorry, you didn't tell me. So why are you guys quiet?
You didn't share your screen. I was saying it only I realized I was on mute.
You people are abusing me, you know. Yeah, you're abusing me now. Why didn't you tell me? Okay, I'm sorry about that. I just I didn't remember that I had stopped it before we went for break. So this is where I am. Medications to prevent organ rejection. I told you they are immunosuppressants, corticosteroids, cytotoxic, and antibodies. Those are the 4 types of medications they will give for organ rejection, or for a patient that has kidney transplant. They give this for protection. Jennifer, why are you eating my stuff? Huh? Okay, so those are the medications. 4 of them: immunosuppressants, steroids, cytotoxic, and antibodies. And if there's the need to combine 2 different immunosuppressant medications, let me get my marker. If there's the need to combine 2 of them, if they have to combine 2 of these medications, then they give them in low doses. They cannot give them in higher doses. If they have to combine 2 steroids to give it to you to make it work, they give it in low doses. Cytotoxic to low. Antibodies to come as a form of medication. They give it in low doses. So because it helps produce possibility of any adverse effect, they don't want to overdose you with steroid. So we have medications. I need to cancel this one. Okay, so medications that help, these medications I just mentioned these are immunosuppressants. So this is the one I was putting the bracket, and I told you NCLEX like to use the brand names. So in case, but most often when they are giving you medications and they don't want to confuse you, they can put the brand name and the generic in bracket. So take note that I like to use the brand names because NCLEX like to use those ones for students. But besides that, when they see they put Solilimos and they put something in brackets and they put another name, it's the same thing. They have the brand and the generic. So these 3 are the immunosuppressants. These 3 are immunosuppressants. So take notice of them. Then we have the glucocorticoids. That's the steroid. Steroid is just prednisone. So prednisone is part of kidney rejection medication that they will give. Cytotoxic medication, azathioprine, mycotosporin, and mycophenolate mofetil. So these are the 3 medications for cytotoxic medication. Then we have the antibodies. We have anti-monocyte globulin and basilizumab and cyclosporin. When you look at the antibody medication, this is similar to the one they give for the COVID. They are all antibodies. So all the antibodies will have the zimab something. So anytime you see all those zimabs, they are antibody medications that they give. When you get to SARS, respiratory syndrome, they use antibodies as well. So that's where COVID belongs. So cyclosporin, basilizumab, and antitomycite globulin. These are the antibodies that they give for patients that are having kidney rejection. So cyclosporin will inhibit, I'm not going to go into this one for the level of the LPN. I am concerned about this one. They say prednisone may be administered concurrently. That's fine. That's the one you combine it. Cyclosporin may be used to prevent rejection, allergenic kidney liver. That's fine. I don't need that. Blood levels of medication should be measured regularly. Jennifer, you're making noise. Get up and go out. and close the door. Bye. Bye. Okay. So blood levels of the medication should be monitored. One second. I know you don't want to go out, so you don't know how to open the door today. Go. Goodbye. See a little boy playing tricks. He don't want to go, so he don't know how to open the door today. Okay, blood levels of the medication should be measured regularly because of its nephrotoxic effect. Blood levels. So you remember I had mentioned that a patient taking phenytoin, they do the levels. A patient taking Depakote, they do the level. They want to measure the level of the medication in the patient's body. So that if it's high, they reduce the dosage. If it's low, they increase the dosage. Coumadin or warfarin, they also check the PTT-INR before they keep administering the medication. So if the patient PTT-INR is high, they reduce the dosage. If it's low today, they increase the dosage. So patients that get the cytotoxic medications, they keep measuring the level. So when they measure the level, they try to adjust the medication based on how much the patient needs, because they can cause it has a nephrotoxic effect. It has an impact on the kidneys or the nephrons that affect the kidney functional units, which are the nephrons. So you don't want to be giving the patient medication to help maintain the kidney, and you keep loading them with the medication. You're not checking the blood level, and it's high in the blood, and the blood keep going and dropping inside the glomerular capillary, which has to filter it. It will destroy them. It will cause a toxic effect of the nephrons or the glomerular capillaries that contains that where the nephrons are, that does the filtration. It will cause a distraction. So you don't want to give that. So you have to let the patients know that they'll be checking the blood. So if, for instance, a patient is had a kidney transplant, and every week they come to draw the patient's blood for blood work, and today you, the nurse, walk in to draw the patient blood, and the patient said, I don't understand, why do the nurses or the doctors keep, or whoever is doing the blood work, every day they keep poking me with needle? Can this whole thing just stop? What would you do? This is a sample way NCLEX can present it to you. Why can't this every week blood draws just stop? Why do they keep poking me with a needle that hurts so much? So you have to explain to the patient that because you had a kidney transplant, you are on kidney transplant rejection medications, or your kidney is failing and they're giving you the medications. The transplant you had is beginning to have a problem, and they're giving you medications that will help sustain it. So, and those medications, they have to continuously check your blood levels to make sure that they are not giving you too much of the medication. If it's too much, they will reduce the medication. If it's too less, they will increase the dosage. So that's the explanation you give to a patient that is concerned that every week you're drawing my blood and has had a kidney transplant. They don't know why. Okay. Now let's move on. The client should be instructed to monitor for early signs of infection and report the signs of infection immediately. So, for instance, I had a patient who was having a kidney rejection. The patient has been functioning normally. The patient walks, and all of a sudden I walk in and the patient cannot walk that day. The patient cannot get out of bed. Patient complain of body aches, fatigue. The patient says, I have pain to my right side of abdomen. I am not able to pee all night. I haven't been able to pee, and I have pain, there's fever. And when we did the blood level, the patient had elevated creatinine and BUN. So it tells you that this is a sign of kidney rejection or transplant rejection, because the patient had transplant. And then another thing you see is swelling, edema. You see it. The patient body will look puffy. They have started accumulating fluid all over again. So such a patient, he had to go back on dialysis. They have to go back on dialysis. So patients who have chronic rejection, sometimes they put them on dialysis too. So you tell them to monitor for signs of infection immediately. To promote palatability, instruct the client to mix the liquid medication with milk, chocolate, or orange juice just before administration. So those medications doesn't really taste good. In fact, it doesn't taste yummy. It's not fun at all. Some of them, they smell too. So you want them to minimize that effect because it can increase non-compliance. Remember, NCLEX try to test your knowledge about compliance to medications. So if a patient is compliant to medications, you assess for factors that can possibly cause the non-compliance. So you assess for why the patient is not compliant to the medication in the first place. Consuming grape juice is prohibited because it raises cyclosporin levels and increases the risk for toxicity. So a patient on kidney transplant medication or kidney rejection medication, instruct them not to take grapes. Grapes is not a friend of urinary tract disorders. Grapes is not a friend. You can instruct them to drink, what's that red juice? I forgot the name of the red juice. The one that will acidify the urine. The one that will acidify the urine.
Is it fruit juice? Cranberry.
Cranberry, yes. Cranberry. Cranberry is a good juice for UTIs and it helps acidify the urine, make your urine more acidic. So it's a good juice for that. So you can, but for grape juice, no, you don't advise the patient to take it. We have the ketoconazole, erythromycin. These are different forms of antibiotics you can give to the patient, and amphotericin B, they can elevate cyclosporin levels. So if for some reason you have to give the patient these medications and the patient is already taking cyclosporin, which is an antibody, these medications can cause elevated. It can cause elevate the levels of the cyclosporin. So you don't want to give it. So take notice of erythromycin. A patient that is taking a kidney rejection medication, including antibodies, and the patient tells you, I take erythromycin. They are not supposed to take it. Let's move to phenytoin. I see phenytoin here. I wanted to jump that. So phenobarbital, phenytoin, rifampicin or rifampin, tremetoprazole can decrease cyclosporin level. So take note. We remember that sulfamethoxazole, it was one of the sulfonamides. If I remember very well, it was in the sulfonamide class. Now they are saying they can, what is that? This one. This is the medication. It's used for UTI, urinary tract infection. Now the patient here getting a kidney rejection medication, and they said it interacts with cyclosporin, so you don't give it. You don't give it. So there are two medications for urinary tract system, but you still need to be careful. Phenytoin or phenobarbital, rifampicin. These are this one and this one are anesthesia medications. Rifampin is medication for usually tuberculosis. Then we have this one for another UTI. So those medications will decrease the cyclosporin level. So you want to take notice. So if a patient is taking cyclosporin and the patient has an order for any of these medications, you want to question the provider because you have the understanding that they can decrease the level of the medication. So that means the function of the cyclosporin to help prevent the kidney rejection will be inhibited. It will not function well. So you question the provider if the patient has this medication. Renal damage can be intensified by the concurrent use of nephrotoxic medications. So if you keep using too much of the nephrotoxic medications, you end up also damaging the renal system, the kidneys as well. Let's look at the Solimos. Solimos is used for prevention of renal transplant rejection. Listen, one thing I'm going to tell you is just have it in mind that I'm not going to go over them one after the other. Solimus, tacrolimus, and cyclosporin, they are all medications for kidney rejection, and they are immunosuppressants. Get them straight like that. And note that cyclosporin cannot go with sulfur, a type of sulfonamide, cannot go with sulfonamide for UTI. And you also know that cyclosporin can also be an antibody as well, can also be given as an antibody as well. But besides that, prednisone is a glucocorticoid, it's a steroid medication. So you can give it concurrently, but in lower doses. I want you to take it like that. I'm not going to go over them one after the other. Do we get it?
Yeah. Okay.
And the cytotoxic medications, maybe I can tackle that one after the other, because that might be a little new. But so the cytotoxic medication, we have the azathioprine. Azathioprine suppresses cell-mediated. Listen, let's look at contraindications. Don't worry about that. You know it's cytotoxic. That's how I want you to understand it. Cytotoxic medication for kidney transplant medication. Know the names and the medications. So they can cause neutropenia, and then they are contraindicated for pregnant women. So if a woman is even pregnant, you don't talk about those medications. So you monitor hematocrit, white blood cell, platelet, liver count, and liver enzyme level, and coagulation factors. Let's look at the adverse effect of myclophenolate. Myclophenolate mofetil the adverse effect is diarrhea, which is a common side effect for most medications, and it may be used with cyclosporin or tacrolimus and glucocorticoids for anaphylaxis against organ rejection. That's why it's already given as a cytotoxic medication. I'm going to jump this. So persons who have undergone organ transplants, such as kidneys, must take the prescribed medications. They must take the prescribed immunosuppressant medications at the same time each day to make sure that the immune system sufficiently suppressed to prevent organ rejection. So you have to take it same time every day to ensure the continuity or the same level of your blood maintaining all those medications. So if you took the medications today, 6 p.m., tomorrow you're taking it at 6 p.m. If tomorrow you decide to take it at 9 p.m., remember, after 6 p.m., your blood level for the medication start dropping. So it's not consistent. But to maintain an equivalent balance of the blood levels of those medications in your body, you want to keep them at the same time every day. So we have this one, balizimab, as antibody. So this is an antibody medication. It's used primarily as an induction agent at the time of transplantation. So the time they're about to give the kidney transplant, they're about to do the surgery, they give you the antibody against it already before you take it. So it is administered by IV route. Initial dose is administered 2 hours before transplant, before the kidney transplant. And the side effects will include headache, insomnia, dizziness, tremors, chest pain, gastrointestinal edema, shortness of breath, pain in the joint, and slow wound healing can occur. So this is common with most of the antibodies. The patient getting antibodies for COVID as well can have these same symptoms. So take note of the side effect for the antibody, balizimab. Any medication that ends in zimab is antibody medication. Anti-hemocyte globulin. This is another form of antibody, and it is used to treat acute rejection episodes. Acute rejection. Remember, acute rejection starts after a month after the transplantation. Hyperacute is 24 hours, 48 hours, within 2 days. Hyperacute, and they take the kidney out right away and put you back on dialysis. That's the intervention. So before the first infusion, the client should undergo intradermal skin testing to determine hypersensitivity. It's an antibody. So they want to know if your body is going to be allergic to it before they give it to you. So they do an intradermal skin hypersensitivity test, or intradermal. So they inject it into the skin, just like they do, you know, the PPD that they do the skin testing. They do that to determine if you are allergic to. But remember, the balizumab is given at the time of transplant, 2 hours before the patient go in for the surgery to have a kidney transplant. They give you antibodies so that when they put it in, your body will have enough antibodies to fight. Hematopoietic growth factors. We have the hematopoietic growth factors, and these are alpha. These are medications that help make up blood. They are medications that help produce more blood in the body, especially patients with kidney failure. They have problems with blood levels because the kidney is not doing a proper regulation, and most of them become anemic. So they have these blood levels, hematopoietic, depapoietin alpha, and peginacetide. So they give it to them. These are medications that help with production of red blood cells. So mostly when you see patients taking this one, you question their kidney function status. Patients with kidney issues take those medications. So they stimulate the production of red blood cells. They are used to treat anemia for chronic kidney diseases. So patients with chronic kidney diseases, you always see alpha. There's another one that we have. I don't know if they are going to mention it somewhere, but this is what is called epogen. So either epoetin alpha or epogen is the same medication. I haven't seen them mention that, but that one is another chronic kidney disease medication. So you always see these medications in patients that are having kidney problems, chronic kidney disease, chemotherapy-induced anemia, anemia caused by zidovudine, and anemia in clients requiring surgery. So initial effect can be seen within 1 to 2 weeks, and the hematocrit reaches normal levels in 2 to 3 months. The major side effect is hypertension. So when you keep giving me this one to create more blood cells, I create plenty of them, and then the patient becomes hypertensive. So side effects or adverse effects will include heart failure, thrombotic effects such as stroke, myocardial infarction, and cardiac arrest. So because the patient's kidney are failing, these are the medications you give. That's the hematopoietic growth factor. Hemo, we know the hemo will mean blood, so blood production medications. Epogen, alpha, they are a form of iron. That's the form of iron the chronic kidney patients take. The patients that have anemia because they have started chemotherapy, they get these medications. Most of them will be IV form of it, and they just push it into the patient's body, and they work faster. If you don't have that, the other thing to prevent anemia is they give you iron fesolate. The fesolate is not usually, it doesn't work so well for them. So that's why they go with this epogen or alpha epoetin. They use that one. Zidovudine is usually a medication used for HIV. It's an antiviral medication. So if it has a side effect of anemia, so if it causes anemia, they can give that medication too. Now let's look at leukopoietic growth factors. Leukopoietic growth factors. So this has to do with white blood cell medications that will help produce more white blood cells, that will stimulate the production of white blood cells. This has to also do with the renal system as well. We have the filgrastim, we have the perfilgrastim, and sagramostim. That's funny. But listen, understand that there are medications that will help produce white blood cells when it comes to kidney problems, especially when it comes to suppressive, when it comes to bone marrow transplantation, bone marrow issues. it all have to link up with the kidney. So these medications will stimulate the production of white blood cells, which they also call leukocytes. And they are used for clients undergoing myelosuppressive chemotherapy or bone marrow transplantation, and those with severe chronic neutropenia. Neutropenia is low white blood cell. Neutropenia is low white blood cell. Okay. So if your white blood cells are low, we call that neutropenia. Neutropenia. If they are elevated, you have an infection. If they are low, neutropenia. So patients that keep having neutropenia, low, are mostly cancer stuff. You want to think cancer. When they're talking about neutropenia, you want to relate it to cancer. So patients that have cancer, their white blood cells are low. Instead of high to be infection, it's not infection. If it's low, you're thinking cancer. Medications for benign prostate hyperplasia, BPH. Medications for, oh, I think I jumped this one. Thrombopoietic growth. This stimulates production of platelets. They stimulate production of platelets. So, but remember the leukopoietic medications are there for bone marrow transplantation issues and bone seed, and then neutropenia, as I said. So because of that, they can cause bone pain, leukocytosis, that's inflammation, and then inflammation of the cells in the bone marrow, and elevation of plasma uric acid, lactate degeneration. I'm gonna end it there. I'm gonna leave that one there. It's fine. Thrombopoietic growth factors will stimulate the production of platelets, used for clients undergoing myelosuppressive chemotherapy as well, to minimize thrombocytopenia and to decrease the need for platelet transfusions. So effects will include fluid retention, cardiac dysrhythmia, conjunctivitis. This is so detailed. Just understand that we have white blood cell stimulating factor medication, and these are the names. We have the red blood cells. For especially chronic kidney diseases, they will need these medications. So the patient keep getting iron, come to tell you that every day, and this epogen and depapoetin, they look black, very black. So it's an IV medication you draw and give it to the patient. So when you're giving it to the patient, I don't know who has ever seen iron in the liquid form. They look very black. I have some. When you're giving it, it looks very black. And you know that iron can stain the teeth. So if you give iron that is liquid form, it has the side effect of staining the teeth to look black. That's why you see most children with black teeth. If you remember seeing that years ago or in children. Lately, parents are all aware, they do proper education on that. So we hardly would see that, but when you see children with black teeth, you want to question the mother if the child is taking iron. The mother comes to you telling you, my baby's teeth has been white and beautiful, but for the past 2 months, it started becoming black. I don't know what's going on. I want the doctor to see it. You have to educate the mother. You have to find out, assess first. Does the child take any iron syrup, any liquid iron? It will cause the teeth to be black. Now, I'm explaining that in regards to this medication. If a patient is having a chronic kidney disease on hemodialysis and come to tell you that I have been taking iron pills already, or you're giving this medication, you're giving the patient alpha epogen or epoetin, and the patient tells you, oh, it's okay, I don't think I need that. I have been taking PO iron. I've been taking iron at home, so I don't think I need that. And my primary care doctor told me to take it, and I used to take it, and now I still take it since I have the kidney failure. So you have to educate this patient, because the absorption of the PO iron is not going to be effective enough to help produce red blood cells. They rather need the IV form of the medication. They rather need the epoetin, the hematopoietic growth factors, to help build red blood cells in their body. PO iron, that is not always effective in patients with chronic kidney disease. That was just by the way. Now, let's look at medications for BPH, benign prostate hyperplasia. Do we know that BPH is mostly in men? Do we know that?
No, I didn't know that.
Is that
I did not know.
BPH?
I didn't know it was all mostly in men.
Have you ever seen a lady with a prostate?
Oh.
Okay, so prostate is in men. So
Oh, yeah.
they have inflammation of their prostate gland. When there's enlargement of the prostate gland. I think I spoke about this, benign prostate. Were you there last week? You were there, like, right, Beverly?
Yes.
You know, maybe that's why you are not understanding. You know, all these medications I'm treating, they all fall under the disease conditions for renal system. That's how I tackle it. So I tackle the disease conditions first. And now I come to tell you all the medications that are given for all those conditions. Remember, I talked about kidney transplant. Now, these are the medications they give for kidney transplants. Maybe I should be putting them together at once so that when I finish talking about kidney transplant, I tell you the medications. If that will work, I can combine them like that. So, for instance, if a patient has cystitis, the medications we spoke about, sulfonamide, those are medications you give. So all these medications are equal to the disease conditions I spoke about. Cystitis, I spoke about glomerular nephritis. All these medications are medications that are grouped to treat them. So this is just like side by side. So I get this benign prostate hyperplasia, then these are the medications you give. So I assume that I had spoken about the disease conditions before I now bring up the medications. That's why I grouped the class like that. So I tackle the disease conditions and then I now tackle the medications to treat them. I don't know if you understand me that way. So let me tell you if you want to learn this. So if you want to learn this, you now take the notes that I sent you for the renal system diseases. And then you go to benign prostate hyperplasia. It's a disease condition I spoke about. So you read the condition. When you finish, you read signs and symptoms and your intervention if a patient has that condition. Then you come here and you read the medications. What are the medications to be given? So I think maybe I should be combining it like that instead of separating the medications separate to make you understand that I have tackled all these systems, all these disease conditions, and I'm not talking about their medication. So for benign prostate hyperplasia, I had mentioned that prostate is the enlargement of the prostate gland. When you look at the prostate disorders. Let me just get that. I want to make sure you never forget that this is a disease so only for men.
Only for men.
Yeah, because women, we don't have a prostate. See them walking and it's like a big bag hanging down there. Urinary system. So just give me a minute. Let me search for this. We're almost done. That's the last one we're talking about. So don't worry if I decide to now look for it.
absolutely sure.
All right, Beverly, I changed my screen. Can we look at the screen now?
Yes.
You see the disease condition here that I spoke about? I said benign prostate hyperplasia or hypertrophy is a slow enlargement of the prostate gland with hypertrophy and hyperplasia of normal tissues. So the normal tissues in the prostate gland become enlarged. They become enlarged and increase in size. And enlargement will compress the urethra. That results in partial complete obstruction. Partial complete obstruction. So these people will have urinary urgency and urinary frequency. They'll feel like urinating every few minutes. The patient will tell you, in the night, I don't sleep. I go to bathroom every 30 minutes. But when I go, I'm not able to pee everything out. I feel like I still need to go. So I keep going back and forth. So because the prostate gland is enlarged, it puts pressure on the urethra. Remember, the urethra is from the urinary bladder to the exit. So from the urinary bladder in every human being, ladies have a shorter urethra, men have a longer one because of their long gland. So the prostate gland is underneath just by the testicles. So it gets enlarged and it puts pressure in the urethra that help allow the urine to pass through. So the urethra are the tubes that move from the bladder, urinary bladder down to the exit. So that's where you pee from. So if the enlargement occurs at where the urine will be flowing, then it puts pressure on the ureters, and the ureters are not able to release everything. And every time you have the urge, you have the feeling that you have to pee and it's not coming. So usually this occurs in men 50 years and older. So 50 years and older, they have that problem. But they advise men starting age 45 or so to start doing their testicular checks and all those assessments for all those things. So we have the assessment. You see diminished and force of urinary system. That's early sign of BPH. You see that the patient is forcing to urinate and it's not coming. We have the urine urgency and frequency, nocturia, that's the one I spoke about, urinating in the night. Inability to start, hesitancy or continue in urinary stream. And it's dribbling. You pee, you start peeing. You know what? Mostly when men are peeing, it goes so straight. But this person is peeing and it dropping and so it dropped for some few seconds, 1, 2, 3 drops, and then it stopped. Then the person is standing waiting because you still have the urge to pee and it's not coming. So that's the urinary urge and the hesitancy, inability to pee. You want to, but you cannot. So you encourage them to take a lot of fluid, 2,000 to 3,000 daily, unless it is contraindicated. Do you now understand? Beverly?
Yeah.
You now understand that BPH is purposely for men?
Yeah, no.
And it's because they have a prostate.
Yeah.
So these are the medications. So if a patient has BPH, these are the medications you give.
Okay.
That's it. So that's how my lesson note is planned to correlate with each other. So the disease conditions that I present, the pharmacological component is supposed to tackle those disease conditions. So you give the patient alfuzosin, but I realized that if I put them together, that was what I thought about. If I put the disease conditions together with the pharmacology, sometimes when I get to the pharmacological part, we lose interest in the study. We lose interest in the study. But when you understand the disease condition and then you come to think about the medication, you just need to know 1 or 2 things more about the medications and the contraindications. So I have also been a student and I'm always a student. So I understand that If I put them together, and then you will be eager to understand the disease signs and symptoms, you be eager to understand the nursing component. But when it comes to the medications, because some of them, their names even look like botanical names that you don't even understand where they're coming from, it kind of kills your interest in understanding the whole disease processing. That's why I separated the pharmacological component of it. So we have the alfuzosin, we have the doxazosin, we have the tamsulosin. Do you ever remember this medication anywhere, Beverly?
No.
Tamsulosin, this medication, patients in nursing homes, a lot of them take it.
Mm.
If you have ever been there, you will see that a lot of them take it, tamsulosin. Alpha blockers, silodosin. So we have relaxed muscle neck. So these medications, what they do is, if a patient has the enlarged prostate, they will help relax the neck of the bladder muscle and fibers in the prostate that allow urine to pass easily. And the adverse effect will include dizziness and retrograde ejaculation. So the patient can have an unusual ejaculation for taking this medication. So we have the alpha induction inhibitors. I'm not going to talk about this. Don't worry about these medications, but take note of this particular one, finasteride. Finasteride is a medication. They like to talk about that medication. It's an alpha medication. So when you see finasteride, it's a medication used for BPH. This is how it's spelled. It's a medication used for BPH. So take notice of that medication. They like it. Adverse effect will include retrograde ejaculation, the same thing. So it's a medication for BPH, and it can cause abnormal ejaculation for no reason. And the effect of these two medications is to shrink the prostate by preventing hormonal changes that result in growth of the effective that result in growth of the prostate gland. It should be growth of the prostate gland, abnormal growth of the prostate gland. Because you have the prostate growing, which is not normal. So they shrink them instead of having it expand, abnormal enlargement and hyperplasia. Finasteride, dutasteride is supposed to shrink. So when it shrinks, it cannot be larger. That, like I said, if you have ever seen a patient who has it, and it's like a big bag hanging down there. They'll be walking and it's like they cannot even walk well. They're walking like a pregnant woman in labor. The legs are apart because the prostate sometimes get very big, like a football that is hanging down there, and it's uncomfortable. Their problem is frequency of urine. They have urine frequency. They always feel the edge of urinating and they cannot urinate. In the night, they don't sleep. They run to the bathroom all night. So you want to encourage them to drink a lot of fluids. And when they start taking medications that will help, the medication can cause abnormal ejaculation. This is a common medication people take for BPH, and this one too is a common medication they take for BPH. 1, 2, 3. 1, 2, 3. They are the common 3 medications they take for BPH. So take note of them. And their adverse effect is the first one, doxazosin and tamsulosin, is to help relax the muscle. It's to help relax the neck muscle and muscle fibers in the prostate gland that allow urine to pass. Let me show you the urinary system and where that thing falls. Because I remember I showed you that before. We are done with the system, so I'm just going over stuff. That's it. Besides that, we are done. So you see, these are the muscles. This is the one that tells you that your bladder is full. So patients that have the enlargement is underneath below this one. So it's putting pressure on this. It tells you your bladder is full. Then you get to the bathroom. This is the muscle that is supposed to tell your mind to open up and you urinate. Then you get to the bathroom, and it's not doing its work because there's an enlargement that is putting pressure on it. So your mind is ready to pee, but it's not coming because these muscles have to relax. They have to do contraction and relaxation to be able to release the urine through the ureters. So these are the ureters. That will help. So there's a closure muscle here. So this one here, the muscle here, keep it closed. So if the enlargement is there, there's pressure on it. So it causes a reduction in the amount of urine that is supposed to flow. But remember, these ones are all working and they keep producing the urine. So it's full in here, but it's not able to come out. It's full inside the bladder and it's not able to come out. And the kidneys keep making more urine because your system is functioning. Your kidneys are not affected. It's your prostate that is affected. And the prostate is located at a lower portion. And then it put pressure to the side that is supposed to release urine. Do I make sense with this one? Hmm?
Yes.
Do we have any question?
No,
Any question?
I don't have one.
You don't have a question? If there is no question, let me look at our time. Yes, we can start here. It's been a lot of materials we have gone over, but I'm